But I think digital health is something that is inherently interdisciplinary. So as Rick Hobbs was saying, not only is medicine a team sport, technology is also a team sport, but if you want to take that and have it applied, you have to bring in all these different elements as well. And one of the things I really wanted to bring into this talk today was humanities. There's a number of different things, as Jonathan Mustafa was saying this morning, ethics is a big consideration. But in searching for people who can really speak to digital health and humanities, that's what brought me to Sarah Singer, our next speaker. And she's great. And I'm excited about her talk today and where this is going to go. But also, she's been a great connector to me, connecting me with H-Hive, which is the health and humanities on campus, also with the Digital Humanities Lab. We've already reached out to them. So this is a nice way of building out the connection that we've seen from in my position, not only in health affairs and technology, but where it reaches the rest of campus as well. So with that, I'll pass you on to Sarah Singer. Yeah, you can wear it or hold it, however you want to do it.
Good morning. How's everyone doing today? Pleased to hear that. My name is Sarah Singer, and I'm coming to you all the way from the Department of English and Comparative Literature. So if you're ever on that side of campus, next to the pit, and perhaps most importantly, next to the Lenore Dining Hall where Chick-fil-A is located, you will see our building. We're in Greenlaw Hall. But before I get started today, I want to encourage you to tweet this session and all of the sessions. I'm 2_ at Sarah Singer. And if you have a digital device with you that accesses the internet, for some reason my device was not accessing the internet very well, I encourage you to go to this link here. So it's http://bit.ly.2on capital Y capital O lowercase s, capital A. We're going to do an interactive activity in the middle of the presentation, and we kind of share our notes and thoughts in this Google Doc. So take a minute and get set up, and I'll tell you a little bit about me. So here I am, I'm from the Department of English and Comparative Literature, and you must be thinking, what is an English student doing here at the Digital Health Symposium? In a certain way, I was wondering this myself. But there's actually a lot of connectivity between what's happening in the humanities, what's happening here across the university. It's really exciting. So what you might imagine an English doctoral student to be doing is reading novels. Does anyone know an English doctoral student in the humanities? I do know one of them. So what many of those people do is they look at contemporary and historical novels, they do analyses of those novels, they contextualize them, they put criticism of those novels in conversation with other criticism. But instead of that, my research is broadly examining the connections between rhetoric, or the study and art of persuasion, health, science, technology, and those sorts of things. So instead of studying traditional novels, I'm studying healthcare manuals, I'm studying brochures. I look at peer-reviewed journal articles that people love to read, right? You love to read a peer-reviewed journal article, all those sections. So that's the kind of work that I'm doing here. And so specifically, I work on Lyme disease. How many of you here have heard of Lyme disease? Oh, that's good. So particularly, I'm interested in Lyme because it's a chronic and contested illness. And so one of the issues is, as patients, we have a lot of opportunities to use digital health resources. We can look on Facebook and get support groups. We can look at the CDC website and figure out what it is that the government believes about Lyme disease. We can look all across the internet. But the problem is that all of these different resources are coming from different orientations. And so one way that I think the humanities particularly can intervene in this digital health conversation is to talk about who is persuading what and to do whom. So this presentation is going to cover a couple of things. So first, I'm going to talk to you about what digital health rhetoric is. And so to me, digital health rhetoric is how digital devices and platforms make arguments. And they do this both explicitly and implicitly. So in ways that we notice immediately, and then in other ways that we have to take time to really sort of process and figure out. I'm also hoping to talk to you today about how this works. So, and best of all, instead of me just talking at you about it, I'm going to ask you to engage in some of this work yourselves. Because it's really integral that people, not just rhetoricians like me, but that people from all across the university, from technology backgrounds, from corporate backgrounds, are able to do this kind of work too. Because ultimately, it will probably benefit them economically and personally, and it will give them just a totally different insight into the kinds of information patients are seeing and experiencing. And you should know that there's a lot of different types of digital health research. We've talked about a bunch of kinds this morning. Certainly people from the humanities like me are very interested right now in wearable technology, and so the embodied experience of wearing something and how it might persuade you to do something or not to do something. They're interested in the social media presences of individual clinicians as well as large groups like the NIH. So this is just one small branch of research. So I don't want you to think that it's limited. The humanities, part of what's really fun is we can do a lot of things. So, what is digital health rhetoric? We've started talking about that here. And so first I think it's really important to define rhetoric. Who took a rhetoric course in college? Does anyone remember anything about rhetoric? So some of those Greek philosophers, we've got some Aristotle. So I'd say the most common definition of rhetoric is about the available means of persuasion. So that's an Aristotelian definition. And I think what Aristotle is talking about there is that we're doing whatever we can, whether it's using persuasive images of sick children, whether it's framing something to be about the user to be in second person, or whatever we can to make something really interesting and appealing to someone else, and perhaps to persuade them to come over to our point of view. Now, when most people hear about rhetoric today, they're thinking about politicians and other people using language and images and those sorts of things for nefarious purposes. Has anyone seen an example of this lately? Many of us. But I want to think about rhetoric more expansively. So it's not just about using these things to make people do things that they might not necessarily want to do, but it's about understanding the context and orientation of language and ideas. And this is really important because patients have access to so many different resources. So this is merely my Google search for Lyme disease, which is the case study I'm going to show you today. So as you all know, all these Google searches are constrained by algorithms. So because I research Lyme disease, like these are some of the things that come up. But patients have a lot of options when they look at digital health tools. They don't necessarily just have to go to the CDC. Other resources might be more attractive. And often, particularly as academics, particularly coming from the humanities side of things, where we're really invested in issues of information literacy, we often just really want people to figure out what authoritative knowledge is. So if you can see this list, which might be a little bit difficult. So let's say, so at the top we have the CDC, then we have WebMD, then we have this other website called ALDF, and I'm not sure what that stands for. Then we have Wikipedia, and then we have LymeDisease.org. Which would you say are, which 2, 3 are the most authoritative, would you say? Probably the CDC. So yeah, I mean, potentially, I don't know, it depends on sort of who you're talking to. And so one of the issues that I want to talk to you about today is that patients aren't just looking for authoritative scientific knowledge when they're coming to digital health resources. Instead, they're searching for a whole lot of things. And by using rhetorical analysis, which I'm going to teach you how to do, you're going to be able to see what some of those things are and then consider potentially, depending on what you do, augmenting some of the things that you do, or even just sort of listening to other potential voices and perspectives so that your information can be better processed and received. So, has anyone done a rhetorical analysis before? Potentially, a few? Okay, so people have been talking about rhetoric for thousands of years. So for me to pull it down into 6 particular bullet points seems, I don't know, other people would probably be offended by that. But let's talk about these possibilities here. So first we have attention. So what I would say the first step of a rhetorical analysis is to figure out what part of a resource is really captivating. What are you looking at first? What's really most interesting to you? What are you noticing? We then got what's absent. And sometimes this can be more difficult because you're sort of bombarded with all these image, with text, with these image-text combinations, with video, and it's hard to imagine what isn't there. But sometimes that's where comparison can help, where you put two sources together, and then you can really see what's missing or there. We then have appearance or arrangement. So what is on a page, how is it organized, what's happening there? And perhaps most importantly, we've got audience. So we're not merely talking about who the audience is supposed to be. So for instance, for the CDC, who do you think their audience is, their intended audience is? Broadly the public. So their information is written, say, at potentially a middle or a high school reading level, or at least ideally it is. Often it's accessed by clinicians, it's accessed by patients. It's supposed to be something sort of that a lot of people can look at. But sometimes, by doing a rhetorical analysis, we can also notice implicit audiences. And so, potentially they are organizations or companies that arise because of lack, things that they don't see on the CDC website, gaps that they can fill. So that's where audience really comes in. And then we have here articulation. So how is something communicated specifically? What kinds of language choices are they using? So for instance, with Lyme disease, there's a lot of contestation just around the term Lyme disease. So are people talking about Lyme disease? Are they talking about post-treatment Lyme disease? Are they talking about chronic Lyme disease? That even merely that terminology is one way to understand the sort of overall argument and persuasive forces at work. And then we have argument. So I would tell you that I think all of these tools are trying to tell us something and make us do something. So often, I think coming from the academy, we see places like the CDC as not having a political purpose. They provide information, they're sharing ideally the most up-to-date scientific knowledge, but I think they actually have these sort of undercurrents of things going on, and it's really important that we notice that. So, let's start with example number 1. So here we have the CDC website. So if you can, pull up your mobile device or whatever device it is you're looking at. So you have a couple of options. You could go to this website on your own device to look at it more clearly. It's cdc.gov/Lyme disease, or you could just Google Lyme disease CDC to look at that page. And if you look at the Google Doc that I had posted, it has those 6 A's, which I will repeat for you. So we've got attention, absence, appearance, audience, articulation, and argument. So either looking at this screen or looking at your own phone, take a couple of minutes and think about what's speaking to you on this page. What's absent, what's there, what's not there, what you're noticing, and then let's come back together as a group to talk about it.
Easier one to write out if you want to go there. But I can
So much better.
so if I created another bit.ly for the thing if people were having trouble getting it, but it's the bit.ly/dh_rhetoric. So if you want to join us on the PowerPoint, dh_rhetoric.
And feel free, if you are already finding things, to post them in our Google Doc. So it'll be one way that we can kind of communicate with each other. Is it okay if I open the tab? All right, take just another 30 seconds. And then let's start to talk about it, because I think immediately some things are going to come to mind for you. Potentially things that you already know about the CDC and their website and their materials, but potentially some new things as well. Oh, and regrettably, I made this a view only. So it turns out that you can't type it on the document as I had intended. So let's just bring it back together and talk about it in person. So here we are. What is it that you're noticing about the CDC website here? What's the first thing that comes to your attention?
Photo.
Video.
So we've got a couple of things. So we've got this photo thing that I think also has a video embedded in it. So, and who is it? Who are they depicting here? An older woman, she looks kind of sad or upset. Perhaps she has a headache. She has that kind of finger pointing, head tilted situation there. Obviously not very happy. This is not someone who has been cured and is happy about their Lyme disease situation. We've also got a lot of text here. Who noticed all of the text? Okay, and what did you notice about the text? Anything in particular?
Too much.
Okay, so there's a lot of text. In theory, we've just got one paragraph here, but in practice, there's a lot going on in that paragraph. So let me read it to you. Lyme disease is caused by the bacterium Borrelia burgdorferi and is transmitted to humans through the bite of infected black-legged ticks. Woo! That is a hefty first sentence, even for me as someone who spends a lot of time researching this stuff. So, and let's read the second sentence. Typical symptoms include fever, headache, fatigue, and a characteristic skin rash called the erythema migrans. So for the average person who thinks that they might have been bit by a tick, how inviting is this page for them? How accessible do you feel like this page is for them?
Not very.
Probably not very. Some people, I think you could argue that this page has a lot of comprehensive information because the following sentences in this paragraph do describe the testing, the results, but they also make it seem quite simplistic. This is a lot of stuff to load into one paragraph. And certainly you can notice here that there's links that would direct you to other pages. But what a lot of patients are looking for is not just this information. They're looking for confirmation, they're looking for sort of things that confirm or deny their fears. They're looking for these other social actions that aren't merely reading this page here. So one of the issues I'm seeing here as well is that the CDC does not acknowledge, or not on this page at least, that Lyme is a really contested condition. And so for patients who have spent even just 5 minutes researching on the internet, this page may suddenly seem less legitimate to them because it doesn't represent sort of what they are beginning to believe about Lyme disease. So this is just one example of where large institutions like the CDC, they do have really comprehensive information. And they do include information that academics, scholars, clinicians, and others find very credible. But for your average patient user, they might not find this very engaging or interesting, and it might not acknowledge their entire experience, and thus might seem less interesting and potentially less useful. So let's look at a second example. So take just a minute. I'll keep this on the screen here, or certainly you can pull it up on your own screen. This is a webpage from the Jemsick Specialty Clinic, and Dr. Jemsick is a doctor who treats Lyme disease. So take just a minute, and then we'll talk about what you notice. All right, start us off. Someone here in the front. What are you noticing?
It's a marketing page, sales pitch.
How can you tell?
Just about everything is about is like accepting new patients. Let's get started. And here's my sign up for my letter. We're here to help.
Definitely. So who do you think is the audience then for this marketing page?
Someone who already has confirmed Lyme disease.
Interesting. So one possibility is someone who already has confirmed Lyme disease. But ultimately, someone doesn't come to this kind of page unless they feel like they haven't gotten the right treatment. People are not seeking this kind of specialty care if their suffering is over. So, to be honest, I think it's pretty easy to be persuaded by this. Here we've got the second person. Lyme disease doesn't have to define you personally. It appears to be appealing to a specific patient. Whereas the CDC page is talking sort of very broadly, Lyme disease is this kind of disease, it's caused by a tick bite, here's how you treat it. It doesn't appear to be accounting for this experience that people are having, and thus might attract them. So you've also noticed this newsletter here. That is absolutely correct. So there's an attempt here to have some kind of engagement with the patient. It's not merely read our website and get information, but instead it's interact with us, share your story, let us know what's going on with you so we can provide you this more personalized care. So it's not simply about giving or getting information. And for really ill patients, it's not simply about evaluating what information has scientific authority. Instead, things like this can be really convincing. So what? why should you care? Many of you are healthcare professionals, many of you are industry leaders and experts, and you're probably saying to yourselves, people just need to get the right information. They need to be finding the right sources. The CDC page did come up first on my Google search. So ideally, that's where people go and they'll get the right information. But there's actually a lot going on for patients here. So they're not just looking for information in their search for healthcare information. Instead, they're looking for potential, alternative treatments. They want something that centers or inspires them. They're looking for affirmation that their concerns are being heard and validated. And especially when this is not happening during clinical encounters, it's very tempting, as you can imagine. There's a lot of persuasive stuff at work here. So to find sources that acknowledge the kinds of uncertainty patients are feeling can be really powerful. So here's what I think that we can do. So as a humanist and as a scholar, I think that we can read both popular and professional sources to better understand the kinds of digital resources that patients are encountering. So, for instance, for those of you who are healthcare providers, you're probably not looking on Pinterest or on Instagram for healthcare information. Would any of you say that those are major sources? No. However, often that's where patients are going. Patients are going to places where they can interact, where they can share stories, where they can be sort of their personalized selves. So, although it seems like it could be hard to take seriously some claims that are coming from those locations, it's important to know that people aren't just looking at the CDC for healthcare information. We also really want, as a patient, I want my doctors to listen to what I have to say. And so sometimes that means acknowledging a controversy, even if it only appears to be a controversy to me and potentially another group of patients. Even if an issue appears to be solved in the medical community, we sometimes still need that confirmation. And we also can write and design in ways that center users. So I'm not necessarily saying that the CDC should redesign their page to say, you have Lyme disease, let us help you. Here's the link about diagnosis. Here's the link about treatment. But at least we can be attentive to the idea that those forces are working really hard and that patients are swayed in different ways based on what's happening. And as a final note, I want to remind everyone too that although these examples sort of make rhetoric appear to be this nefarious thing that convinces patients to go with alternative treatments, it's less about that, but instead thinking about the possibilities for then what rhetoric can do. So can rhetoric help make really difficult scientific information more palatable to regular people? I think there's a lot of possibilities, and I'm looking forward to hearing your questions and engagement. Thank you so much.
Questions?
Yes.
Great presentation. Have you looked at the origin or the value proposition or the values that a particular entity might have and see how aligned? So for the CDC, I would almost think they value epidemiology as kind of a core thing. And when it doesn't represent itself, and there's obviously a gap between what was intended and what's actually happened. So just wondering if there's any thoughts around that.
That's a great question. So unfortunately, people like me are considered medical or healthcare rhetoricians. And we often sort of work in our own circle, where we spend a lot of time critiquing sources like this, but it's hard to then communicate that to the CDC itself. So something that's been really wonderful is on our campus, working with Brian, working with some of these other groups, is a chance for us to make those kind of cross-disciplinary connections. So we would have a chance to say, looking from this rhetorical perspective, the CDC values objectivity, it values research from epidemiology, it values research from public health. But the way this information is presented is not necessarily happening in a way that then non-epidemiologists would believe, if that makes sense.
Right.
So there are opportunities for rhetoricians like me to sort of work in service of medicine. But unfortunately, a lot of what's happening is we sort of work in service of ourselves. Like, oh, you critique this source, I'm going to critique this source. And so I'm hoping that something that we could do today is for you to think about how you might add a humanist to your team, what the value added that we can offer, and how these perspectives might be useful to you. Thank you. Yeah.
So you said you're working on Lyme disease and you're researching it. How are you intending to get that information you're putting together out to people who might be interested in using it?
That's a great question. So right now I'm in the process of interviewing between 20 and 40 people with Lyme disease to hear their stories, and they keep asking, how are we going to know the results of the study? So for me, as someone who is going on the academic job market this fall, I'm looking for a tenure line job. The best thing for me personally to do is to publish in an academic journal in English, so a journal like College English or College Composition and Communication. But how many of you in this audience would say you're a frequent reader of College English, College Composition and Communication? No. So one of my goals is to publish in places like Health Affairs that kind of cross between fields, and then to create an online web presence, probably through some kind of interactive website that would allow people to interact with my data and to use sort of my own skills in rhetoric with sort of dissecting these tools as an opportunity to help patients kind of get better health literacy and physicians see from the patient perspective what's kind of going on. And if you have any ideas, I'd love to hear about them during lunch.
I'd love to talk to you about it.
No, that would be great. Yeah.
So, I don't know if you want to toggle back to the CDC slide. It seemed to me like they were on the right path. I mean, the tile, the sort of done tiles, and here at the bottom, these little tiles that talk about signs and symptoms, tick removal and testing, treatment, post-treatment. The large paragraph is a little off-putting. It's just sort of a lot at once. You feel like you have to, as a user or reader, you have to just stop and think, okay, I'm going to be reading a paragraph here for a moment. Let me get my brain sync. But if they were to break that down into some tiles, because as I read through it, it's really like 3 or 4 pieces there, and it might allow, much like where they were headed here with these bottom tiles, the user, the reader, to quickly say, oh, okay, I want to know exactly this, like symptoms or removal, or what is the scientific definition? What is this all about, really? And I think the video is really not. It's kind of not associated with what you might either, whether wrong or right. It seems to be like more about migraines or something to me. But I don't know, what are your thoughts on that? Does it seem like they were on the right path here, given again that they are the CDC? They're not trying to be health fairs or some other type of group.
I think that's a great question, and that kind of goes back to this first question that was asked too about, with these different appeals, what's happening. So I would say the issue is about their values. And so from this page, what does the CDC appear to value?
Dense information.
Dense information. And quite frankly, they're doing a lot of research. They want people to be able to, access the large amount. Anything else that you can tell that they appear to value from here?
I think they want to put out information that is so authoritative that no one could accuse this government site of putting something up there that they would be accused of bias towards some side or another. And so I think they err on the side of saying, we're not getting into the controversy about how it's treated. We're just giving you the scientific information about it.
I think they have obviously social media front and center,
That's true. Actually, I didn't notice that until now. So in theory, they are trying to connect with people, but it is through these sort of small buttons. I mean, I don't know, so I don't know if there's one right answer. And certainly, I think the CDC's values are really important here. They are front and center. I mean, because what they're trying to do is to make it appear very scientific. There's these different sections with different, titles. But I think one of the problems for users, particularly for people who are really concerned that they have Lyme disease, is that it doesn't attend to all acknowledgement of the potential controversy is this page called Signs and Symptoms of Untreated Lyme Disease, which hints at the idea that there is this untreated problem, what happens, but the way this page is arranged, so another sort of tool of rhetoric is, that is coming first, but that header itself isn't really explaining what's going on. Whereas, to be honest, as a rhetorician, I would say that if the CDC put front and center, there's a controversy, here's all the scientific evidence about why we think the controversy isn't actually controversial, and here's why our treatment guidelines are the way they are, that kind of arrangement would help them be more rhetorically effective. So I think the platform is here, the baseline is here. They've got the right sort of literacy levels, they've got that going on, but I think they need a little bit more. Yes?
It's funny, I looked up on the phone, so the responsive version of it, that's not loading at all, like the and so you see these tiles, which I think are very nice and accessible, but that particular topic is actually the last one. Why is CDC concerned about Lyme disease?
Oh, interesting.
So they have it, but that should be up first.
Often if that's the issue with the controversy. So I would urge you continue to look at public, popular, and professional sources in your search for answers. Thank you all so much.
Thank you.
Awesome. Next, I'd like to introduce Allison Lipscomb. So Allison represents a different perspective on digital health, working for the NC Health and Human Services as a data specialist. And she's seeking to use technology to improve a long-standing farm worker health survey that's been going on for many years. And which it needs to be culturally meaningful to the farm worker and give them an opportunity for health education as well, and as well as gathering data for the government. And I think this is interesting because I think a decade ago, maybe, then this would have been relatively unfathomable to think about doing it in this way. But I think it opens up these new potentials that have never before been possible. So with that, I'll pass it over to you. Thank you.
Thank you, everybody. I feel like I've heard TED Talks all morning, so there's a lot of potential here. There's a lot of exciting things going on. It's really inspiring. The wheels in my mind are turning. But I do bring a different perspective. I work out in the field with farm workers. I don't know a lot about technology. I'm learning a little bit. I'm learning a lot today. I do know a lot about farm worker health, and I know a lot about what our needs are. And so I'm really happy to be here and hearing from you all about how maybe any ideas you all have in the technology that we could use to do our jobs better. So I actually did my maternal and child health degree at UNC around 15 years ago. So it's really exciting to see the growth that's happened on campus and these new initiatives that were talked about earlier. And I also did outreach with farm workers for 8 years out in the mountains. But now I'm at the Office of Rural Health, which is in Raleigh. And I'll go through these slides a little bit quickly. We're the first state office to focus on rural health in the country. And we have various programs that I'll talk about. We don't provide direct patient care, but we administer a lot of programs that support and fund initiatives around the state to support patients that are in need. Here are the different programs. I apologize for the busyness of the slides. This is like our standard template that I didn't design. So they'll get a little bit simplified soon. But we place providers into rural settings. We have rural health centers that we support, community health grants that support a variety of initiatives that different organizations can apply for to support like EHR development, for instance. We have a new rural health information technology team, and I know Donica is here in the back representing. She started this week. That's helping health centers and rural health clinics get connected to the HIEA in North Carolina. And my program is the Farm Worker Health Program, which I'll talk more about. This is the map of our coverage across the state. And now we're into our slides. So the Farm Worker Health Program is a smaller program at the Office of Rural Health. We are actually a HRSA-funded migrant health center, so we get federal funding. And we don't provide services directly like I mentioned before. We contract with 10 contract sites around the state, so you'll see the locations around the state there. There are also 11 migrant health centers that are freestanding in the state, but what we do is kind of fill the gaps where those migrant health centers are not sufficiently meeting the needs. So there are a lot of migrant health centers in the eastern part of the state where there are a lot of farm workers, but you'll see kind of out in the west and in the middle of the state, we have like these smaller programs that provide outreach to farm workers and then piece together care. So our partners include hospitals, health departments, rural health clinics, community health centers, community-based nonprofits, and we provide grants to them to go out and find farm workers. So a big part of our job is outreach. So I was, like I said before, I was an outreach worker in Boone, North Carolina for a long time. Outreach workers go out and visit the farm workers in their houses at night. And I should probably talk a little bit about farm workers, but I'll do that in the next slide. But there are about 150,000 farm workers and their family members in North Carolina, and they face various barriers to care. But our work at the central office, there's a team of 7 of us, and we administer the funds that we give to the contract sites. We track the productivity and quality of services. We comply with federal requirements, and we provide training and technical assistance to outreach staff. And our work is very data dependent, as you can imagine. We have to report back to the federal government on the kind of services that have been provided. So to kind of paint a picture of what farm worker lives can be like and how outreach serves them, I want to read a poem by Dr. Gail Thomas. She's our medical director, and she's also on faculty here at UNC School of Medicine. And her poem was selected as the first place winner of the 2017 Society of Teachers of Family Medicine Poetry and Prose competition. and it's been recently published in the Journal of Family Medicine. And she works on a mobile unit that goes out to farm worker camps on a weekly basis during the summer east of Raleigh near Benson to provide medical care on a van. So here's her poem, The Migrant Farm Worker. We arrive at the twilight to the camp hidden in the fields. Bats swoop low, stars come out. The distant summer thunderstorm flickers and rumbles. He and his fellow farm workers gather. The monotony of dawn to dusk labor broken by our presence. As tables, lanterns, charts, and blood pressure cuffs are set out, he offers us water, hospitality, his handshake. We work to deserve his trust. Bearing witness to his industry and expertise, we inquire after his family, admire photos of those for whom he toils, and race to finish so he can rest before his daily pre-dawn rising. His hands harvesting sweet spring strawberries rash and itch. Is it pesticide or plant? His back bent for hours priding tobacco aches at night. Is it oppressive ergonomics or systems? His eyes, exposed for years to sun and dust, cloud with pterygia. Do they dim his vision of his future? His shoulders bearing heavy bins of sweet potatoes wear at the rotator cuff. Are 45 cents per bin worth what he pays in pain? His arms plunging into ripe berry bushes are scratched and scarred, but how to tend the scars of separation on his soul? His body, brushed by dewy tobacco leaves, involuntarily absorbs nicotine. Why should he bear the burden of our cravings? His mind, once aspiring to creativity, is now depressed by isolation. What could he have created? His heart, justly proud of hard work and provision, is broken by injustice. Does our care, though compassionate, serve as scaffold for the sin? We are the consumers. Is he the consumed? I think it's really nice to have a poem. I think it can tell a lot more than anything I could really describe. But I will kind of add a little bit to that. So, like it's mentioned in the poem, farm workers have a lot of specific health risks. So they have occupational health risks, such as tobacco sickness, which is like an acute nicotine poisoning from exposure to the tobacco leaves, skin rashes, eye irritation, backaches, sun exposure, heat illness. And in addition to that, they experience the mental health and substance abuse concerns of the isolation that they face, being far away from their families, far away from their homes. Also pesticide exposure, of course. And Dr. Thomas didn't mention these in her poem, but we also see a lot of farm workers with severe dental needs, also chronic disease such as hypertension and diabetes. So just to give you also some more context on farm workers in North Carolina, our program served around 10,000 farm workers last year, and they work in crops such as tobacco, Christmas trees in the mountains, sweet potatoes, cucumbers, strawberries, tomatoes, and I'm imagining, has anybody ever seen a farm worker camp here? Not really. They're largely invisible populations. So when I first started doing outreach, it was in Wake County, and so you'd be like next to a suburb in a neighborhood, and next door to that would be a trailer with farm workers, and you might never have known that. So a lot of what our outreach programs do is help break that isolation down and connect them to the outreach workers, and then the outreach workers provide care to them. Farm workers are seasonal and migrant, so you have seasonal workers that stay here year-round and live here year-round but work seasonally in agriculture, and then we have migrant workers who come from Mexico on an annual basis, sometimes with the work visa. Sometimes they migrate up and down the eastern stream from Florida up to New York. A lot of the farm workers we serve are men from Mexico. They may have their families here with us, but a lot of them have family members back home. And despite the increased health risk I talked about earlier, there are a lot of barriers to health care. So not many of them have health insurance. Some of them have gotten health insurance through the Affordable Care Act now. If they have a work visa, they have to get health insurance through that or pay the penalty, which has been interesting. But a lot of them have very low incomes. They can't take off work to go to the doctor, so they depend on evening hours to get care. Of course, there's language barriers, transportation. A lot of them don't have cars. And so that's where we have these outreach. I'm going to go back, actually. So this is what farm worker health outreach looks like. This is one of our sites that's in Benson, east of Raleigh, like I said. And the van you see here is a mobile medical unit. So not all of our sites have mobile medical units, but some do. They bring the clinics out to the fields, and they work until around 10 o'clock at night. So they go out at 5 o'clock, go visit the farm workers in their housing, and come back at 10. Our model really focuses on enabling services, which includes outreach, case management, and health education provided by community health workers, what we call as outreach workers. One big key that I'm going to talk about today is we use something called a health assessment. So the outreach workers will approach each farm worker each season and do a 2-page interview with them about their health needs, and we'll talk more about that. Based on that health assessment, they'll do health education to address topics that come up during the discussion, and they'll also do all the follow-up care afterwards to get them into primary care, dental, behavioral health, specialty, whatever is identified as a need during that health assessment. They also provide the transportation and interpret and do the case management. So it's a very busy job, and one of the real joys, like I say, from doing it myself is getting out there, but also getting to know the farm workers. We have the same farm workers come back year after year, and eventually with my program we got to go to Mexico and meet their families, but there's a lot of relationship building that goes on because you need that trust to access them and their housing. So this is kind of our problem right now. We have a health assessment we've used for many years, as Brian said, and it's 2 pages. The print's gotten tinier and tinier. And because we keep trying to do more and more with it, because we might only see the farm workers once the whole year, and so we try to cover everything we can in that setting. On the flip side of that, if you know anything about motivational interviewing or patient engagement, trying to cover too many things at once could really leave nothing really covered. So we're starting to question that process a little bit. But you can see here, and you can't really see it too well, but the top part is all demographic information. So at the end of the year, we have to report back to HRSA, our funder, through the Universal Data System, UDS report, on who we served. So basically, their demographic information and what services were provided. And the demographic information as well keeps getting bigger and bigger. So it's veteran status, homeless status. They've added sexual orientation and gender identity. So all these questions are asked of every farm worker out in the field. We also check their vitals. So we check blood pressure and BMI. And then there's a series of questions to engage them. So the questions are, do you have any health concerns? Starts out that way. Starts to get more specific. We do a CAGE screening. We do for substance abuse. We do behavioral health screening. We do pesticide exposure screening. And it takes a long time. So we talk about seatbelt use, tobacco use. So again, it's gotten to the point where it takes maybe 20 minutes per patient. At some of these sites, we're trying to reach thousands of patients, and they only have a limited window to engage the patient, which is in the evenings. All the questions as they are asked could prompt health education or follow-up. So that's really some of the point, is to engage in conversation, not just to collect data. And then, on top of collecting all the data, the next day, that's the goal, sometimes it's many months later, the outreach workers come back to the office and enter that data into our data system. So, we're ready for a change. In 2017, we did some surveys, interviews, and focus groups with our central office staff, outreach workers, and farm workers to find out how they felt about doing this health assessment. Not surprisingly, this is the voices from our office and the outreach workers, but the data entry is quite a burden for them. It means less time spent with the patient. The length of the form has gotten burdensome for the farm workers. I know sometimes when we would arrive to camps and we had seen the same farm workers year after year, it was embarrassing because they could repeat the questions back to me. Or sometimes they would avoid us because they were tired of doing the survey. And then I think over time too, now we go to camps, farm workers are on their smartphones. And so I think before, farm workers were really engaged, they were excited we were coming, and it's not that they're not anymore, but now there's competition with the smartphone and the screen. So trying to get them to disengage from the screen to do this paper assessment is more difficult. We'd like to make the questions more open-ended and more patient-directed and not so close. Do you smoke, yes or no? Some questions are very personal. We talk about HIV testing, we talk about behavioral health and substance abuse, and now we talk about sexual orientation and gender identity, all within their housing, so there could be other farm workers around. So, and farm worker voices, key to all this. We did some focus groups this summer in fall with farm workers to find out what they thought. And research shows that farm workers are using smartphones. This was research by Wake Forest in 2012 and 2013, saying that most vulnerable Latino farm workers living in North Carolina own cell phones and a substantial minority own smartphones. That was 5 years ago. It's increased significantly since then. There are a lot of free, not free, very low cost cell phone services coming out of Mexico. So they get their phones before they come. And they're using them, of course. They're using them to engage with their family, engage with music. It cuts down isolation. So we also did some focus groups this summer. They found, farm workers reported they're using their smartphones for WhatsApp, Facebook, video calls, text, to distract themselves. Like I mentioned, mental health is an issue, so they're listening to music, was really important to them. And they're interested in health education videos on their phones. We also talked to them about the health assessment. They said they wouldn't want the relationship with the outreach worker to be replaced by a screen. They really value that human touch. But they are interested in having their own personal health record. Right now we're collecting information and they don't really get it. So they'd love to have a copy of it themselves or have it on their phone. So how can technology help? So we are contracting with, I actually met through Brian, I met Michael Levy with Blue Door, which is a local health innovation design company, to figure out how we can redesign our health assessment, and we are engaging the outreach workers in that process to do so. So next Friday, we're going to have a design session with them to figure out how we could redesign this. Some ideas as well that Michael's group has is, could some of our processes be more automated in the meantime? So could some of that data entry they're doing be done through robotic process automation to get some of that information off the forms into our data system? We're also hoping to develop a mobile app that the outreach workers can take into the field that would collect this information. Also, we've thought about, through Michael, chatbots for health education. So, rather than repeating the same message to farm workers, it's hot outside, drink water, when the time comes and we're having a heat advisory, could we send automated messages out through smartphones and through cell phones to remind farm workers, now is the time to really be careful, take breaks, drink water, and that sort of thing. And I'd love to hear your all's ideas during the Q&A as well. But it's interesting, though, that technology is finally entering this line of work because it has been such a low resource field for so long. We work on paper, we pride ourselves in doing a lot with small resources, but now that technology is more accessible, I think that we can integrate it more. There are some apps already out there, so Contratados is an app where it's almost like Yelp, so farm workers can rate growers, which is kind of nice. And they can share their experiences if they had a bad grower, and that can help people if they have the choice to choose a better grower. Conectate Carolina is an online directory of services in North Carolina for farm workers. Legal Aid North Carolina has a Facebook page which is really active with education. OSHA has a heat advisory app, so we've also, it has it in Spanish as well, so we educate farm workers on that. And then, we have just a second, we actually produced a health education video on health insurance. And I get to be the evil nurse in the video, which was really fun. But it's based on a telenovela style, like a soap opera style, which is really popular with this population. You might not be able to get this going, but that's okay. But in the meantime, I'll talk about, we're also doing more with behavioral health, and we're looking at using telehealth so that So this has been really fun. That's not me. I come later. But that is one of our outreach workers, actually. But that was a really fun video to make last year, and they played it on the buses as workers were coming from Mexico. We're giving the links out to them and encourages them to enroll in health insurance. So there's a lot of potential out there. Like I said, we're looking at using telehealth for behavioral health therapy with farm workers. A lot of farm workers need behavioral health. They're in isolated rural locations without bilingual providers. And our hope is that we can do telehealth, and so that we can reach farm workers even in their own houses to reduce some of the stigma, and connect them with bilingual behavioral health providers in remote locations. There's also a lot of other health monitoring apps such as diet, hypertension, diabetes in Spanish. Univision has a lot of apps as well. And so we're looking at trying to figure out what might be most popular with farm workers and leveraging that and getting that information out to them. Some other possibilities are biomonitors, such as heat in the fields. But that's it. It's kind of growing. a lot of opportunities out there, and we're just at the beginning of it. So I appreciate any feedback you all have on where we might go with this. But let me take this back.
And any questions?
So you said you're working on automating the form, or and is the goal to ultimately provide that personal health record for these farm workers?
Yes.
Would that be, would those two go hand in hand, or do you kind of bring your form in for your needs, and then it might not be so easy to turn around and provide that as a
Right.
personal health record?
So when I did outreach, we collected this information. We made little little paper things where we could write down their blood pressure and give it to them, because I felt like we were taking from them but not giving back. I mean, in the bigger picture, of course, the idea is that we are providing services, but we were taking that information and not sharing it with them. But I think ideally, I don't know we'll have the capacity to afford, but hopefully we could do something that patients can access as well, or at the very least provide like a picture or something of their record that they can take on their phones. And that's really helpful for them, because as they migrate, they can take that health information with them.
Right. I asked them, and we could talk later, but
Sure.
there's quite a bit of commercially available PHR, personal health record
Okay.
solutions out there, and it's been, if folks have followed, it's been a market that's been around for a while, but has not really taken off. And every year, like, oh, this might be the year, this might be the year. And then if you follow Apple, they recently have their health records where they're going to allow you to pull the data from all your multiple patient portals into your own, on your phone only. And so it's headed that way, it seems like.
Yeah.
I mean, Apple's putting a lot behind it as well as others. So, but I realize you're going to have a lot fewer resources than, say, Apple and others.
Yeah, so they better use the resources, that's all.
But you mentioned that the farm workers are not just in North Carolina, like they spend time here and others. So it just seems like, to the extent you can provide it, and I'm sure you're thinking of this, for them to have their own health data, it's just going to, just like we talk about with all others, empowering the patient and informing them, and then they can be their own best advocate.
Definitely. And just to add to that really quickly is that getting results back about immunizations and pap smears. So we ask women, have you had a pap smear? And they'll say, yeah, but they don't have any record of it. So then there's a lot of going back and trying to get that record or having to repeat it. But there could be ways to get that more centralized and be a little bit more efficient. Yeah. Yeah.
Looking at your farm worker program, it looked like you're covering it about half of the state only. What's the funding mechanism, and is there a prospect for improving that coverage, because the eastern half and the western half are kind of not there?
Right, so that was just our 10 contract sites. There are 11 migrant health centers that are funded directly by the government, and those tend to be especially out in the east where there's a really high density of farm workers, and so those are independent community migrant health centers, whereas we're focusing on kind of the gaps already. Going backwards, trying to find that map. But there are some counties that we'd like to expand into, and that's why if we can get to a point where we're using our money more efficiently, then we can look at expanding.
Where does your money come from? I missed that.
HRSA, so the Health Research Services Administration. So this is, like all that eastern part is mostly covered by a network of migrant health centers. Hendersonville has a lot of migrant farm workers, so they have a migrant health center out there. The Watauga area, that's where I was, and then turned into a migrant health center, so they're no longer funded by us. So a lot of these other areas are being covered by other programs.
Are they operated independently, though, you're saying?
Yeah.
So they're like a
Yeah.
for-profit or not-for-profit organization?
No, they're not for profit. So they're community and migrant health centers that are federally funded as well.
Okay.
So but we're funded as a migrant health center, and then rather than provide the services directly, we contract out to these different. It's a non-traditional model. Yeah.
Was there, and I may have missed this, was there an economic impact to North Carolina from migrant workers going for ER care? What's the impact we know?
We don't know, and I think part of that is data not being collected.
Right.
So when I was in Boone, we tried to get that data from the hospital, and I don't think they were even collecting in terms of Spanish speakers versus non-Spanish speakers, which I was really surprised at. But I don't think providers are consistently asking about occupational status. So trying to get that farm workers, because I know some of our sites have been interested in that because they want to say, hey, hospital, you can invest more in our services and we'll help divert some of these ER visits. They're just not able to get that data yet. But it's a great idea. Are there any other questions, ideas? Yeah.
I'm just curious, how supportive are the farmers of working at
Yeah, it really varies. We have some that are much more engaged and inviting. Some are a little more hands-off, and then some that are a little bit more belligerent, that aren't, wanting people on their land, or think that they confuse our health outreach workers with legal aid or a union, because there is the farm worker union in North Carolina. So that's one of the issues, is access to camps. And so documenting when there's issues of access, like some of our outreach workers have been confronted with a farmer with a shotgun. So trying to report that and get that information out there, and to communicate to the growers that this is really a program that can help you and fill in the gaps of needing care that they're not always providing either in terms of insurance, health insurance. So,
Thank you.
all right, thank you.
That was excellent. I'm so happy with so many of these talks. This is wonderful. So for the next about 45 minutes, we have a triple threat, which is lunch, posters, and demos. The poster sessions are across the hall over there. And people can probably direct you if you don't know where they are, but we've got a bunch of posters for you. We've got some demos, so as I mentioned before, they're down this hallway and around here. There's also one up on the 5th floor, so that one is the VR experience, the virtual reality experience for anatomy, with Jason Sherrill, who's going to be speaking to us later on today. But the other ones are ChiCore is here down the hall, CrossCom, which is, so ChiCore does digital health interventions and research. They're a UNC group, and so if you're trying to put something together, they're wonderful people to talk to. CrossCom has AR headset demo, which I'm personally excited about, the Meta 2, which I've never played with before. Gotten to use in a technical manner. The Elite HRV, which we've talked about, is here. Fleet Feet, to scanning your feet, which we've talked about before. Next Gen Interactions is the one upstairs where you can do the VR demo. Keenan Science Library is here with 3D printing and a VR demo, so you can check them out next to the poster session over there. And of course, the Health Sciences Library. You can check out our digital health collection. So if you can check it over there, we have a brochure about it. You can come talk to me about it or to Lynn, and that's down the hall here. So those are our demos. So in the next 45 minutes, to repeat, you can wander around, you can eat, we'll get food out of there, and then you can come and eat it wherever you like. You can check out the posters, check out the demos, talk to each other. And so the way that this is going to go with the food is we're going to go down this hallway here and have the indoor coming in that way to get pizza and food and drinks, and then we'll come out that way. As I mentioned, specialty pizzas from Amante, which is a local favorite, as well as drinks. And we'll come back in this room at 12:30 for the next talk, which is going to be great. Robert Furberg is going to be our next speaker. And that's it. So thanks very much.